everyone for joining us today, and thank you to our co-hosts for having us here. It's really great to be here.
Yeah, of course.
Okay, so as Lori gave a great overview, there's very promising evidence that cash transfers can reduce intimate partner violence. There are some regional gaps in this evidence, so most of the evidence that we have comes from Latin America. And the evidence that we do have from Africa tends to come from NGO programming, which is run at a much smaller scale than some of the government programs of some of our colleagues who are in the room here today. The literature has also not sufficiently covered some of these integrated social protection programs, or what sometimes are referred to as cash plus programs. And another limitation of the studies that were reviewed is that while authors often hypothesize some of the pathways and the mechanisms through which these cash transfers are having impacts, very few studies have been able to quantitatively test those pathways. And so in the current study, we worked with a government program in Ghana, the LEAP 1000 program, and we were trying to understand whether or not a government social protection program, which was targeted to extremely poor rural households that had either a pregnant or a recently pregnant woman, could influence past year prevalence of IPV. We also wanted to test what pathways was this working through, and finally, whether there were any differences based on family structure. So we were looking at differences between monogamous and polygamous households. The LEAP 1000 program is part of the flagship social protection program in Ghana. It stands for Livelihood Empowerment Against Poverty, and the program objectives are to alleviate short-term poverty and encourage long-term investment in human capital. Now, the LEAP 1000 was an add-on to this LEAP program, which was specifically trying to improve nutrition and reduce stunting. And that's why they were targeting pregnant women or women with a child under the age of 12 months to really target those first 1,000 days which determine a lot of stunting. And so that's why it's called the LEAP 1000. This aspect of the program has now been rolled in nationwide. It's part of the general LEAP program. And the program gives a bi-monthly cash transfer of approximately the equivalent of 14 euros. And it also provides a plus component, which is free enrollment into the National Health Insurance Scheme. So households which are participating in LEAP are exempt from paying the are exempt from paying the premium to enroll in the NHIS. So this is an integrated social protection program because it provides both cash and the fee waiver for National Health Insurance Scheme. The initial coverage of this LEAP 1000 component targeting pregnant and recently pregnant women was about 6,220 households in 10 districts in northern Ghana. So our team worked with government and our UNICEF Ghana country office to take advantage of this expansion and do a quasi-experimental longitudinal mixed method impact evaluation. It was 2 years between 2015 and 2017. We looked at all of the households which were targeted for the program, and it also used a proxy means test, which Lori referred to. And so there was a score of eligibility based on poverty and other characteristics of the households, which determined whether or not households were eligible for this program. So the quasi-experimental design takes advantage of that score because there was a threshold for eligibility. And so we were able to compare households just below that threshold, which gained eligibility into the program, to those households just above the threshold, which are very similar in all aspects to the households that were eligible, but just missed the eligibility criteria. We have a sample of analysis that I'm presenting on today from over 2,000 women, and they were interviewed by female enumerators in private settings. And for all of the statistical analyses, I'm not going to go into the details, but we used a difference in difference methodology, and the quasi-experimental component is based on this eligibility cutoff. And you can see the map of Ghana here. We are in 5 districts for the impact evaluation. The pilot was rolled out in 10. We did the impact evaluation in 5 of those in northern Ghana, so the northern region and the upper east region. We measured intimate partner violence using a modified conflict tactics scale, and we asked women whether or not they'd experienced intimate partner violence in the past 12 months. Then we also asked about the frequency. So we asked whether or not in the past 12 months they had experienced it, never, sometimes, or often. And for each of the different types of intimate partner violence that are listed here, controlling behaviors, emotional IPV, physical IPV, and sexual IPV, there were different items that were asked. And so for all of the items, we have never, sometimes, often, and we add all those together to get a scale, and then we standardize that scale based on the mean and the standard deviation of the comparison group. So we have a continuous score for frequency of violence. Now, just to put this into perspective, if we look at the rates of IPV from the DHS, which was administered in 2009, we see that the women in our sample are experiencing approximately double the rates of IPV of the national average. So this is a very high-risk group for IPV. About 66% reported experiencing some form of IPV compared to 35% of the national population. So this is an important group to target because they are at such increased risk. And you can see that of the other types of violence, they're at similarly high rates or high risk. Now, these boxes here, this is basically showing you that cutoff that I talked about. So on the x-axis, we have this proxy means test, which is the eligibility score. And so though that red bar is the threshold. If you're below the red bar, you qualify for the program. If you're above the red bar, you don't qualify for the program. And what you can take away from these boxes is that the rates of IPV were very similar among both the comparison group and the treatment group before the program was rolled out. When we examine the impacts on IPV, we saw that in the full sample, there was no reductions in reports of prevalence of IPV in the past 12 months. So that means that women were not more likely to say that they had not experienced IPV. But when we looked at the monogamous sample, in fact, women were more likely to say they were not experiencing IPV in the past 12 months. So there are differences based on household composition. And women in monogamous households were 5 to 8 percentage points more likely to report that they were not experiencing IPV in the past 12 months. However, there were no impacts on the polygamous women, and the women in polygamous households were actually at increased risk of IPV. When we looked at the frequency of IPV, in fact, in the overall sample, we did see reductions in frequency. So women were reporting IPV less often as a direct result of this LEAP 1000 cash transfer program. We then tried to dig into what are some of the pathways. So we're seeing these impacts, so reductions in the monogamous households and reductions in frequency in the combined sample. So we wanted to dig into why these reductions might be occurring. And looking at those pathways, we saw positive impacts on economic security. Households were less likely to be poor. They were spending more on overall consumption, also on food consumption. Women were reporting higher locus of control. They were reporting more likely to be saving, and they were reporting higher levels of social support. Households were enrolling at higher rates in the National Health Insurance Scheme, and they were seeking care when ill more often. When we looked at some of the other pathways, we did not find evidence supporting those pathways. So there was no impact on self-perceived stress. There was no impact on life satisfaction. And importantly, we saw no increases in partner drinking or expenditures on alcohol. And this is consistent with the global evidence on cash transfers that they do not lead to increases in these temptation goods. Now, some of the other women's decision-making and agency indicators we also did not find any support for. So just to summarize, we found evidence for pathways 1 and 3 that Lori mentioned in her presentation. So women's empowerment and economic security. So to conclude, LEAP 1000 in Ghana reduced the frequency of emotional, physical, and combined IPV. And it reduced the experience of any IPV only in the monogamous sample, not in the polygamous sample, even though women in polygamous households are at higher risk of IPV. Pathways we found support for include economic standing, emotional well-being, and women's empowerment. And these results really underscore that cash transfers can have broad-ranging impacts on dimensions of well-being beyond their main objectives around consumption smoothing, poverty reduction, and investments in human capital. Our findings suggest that family structure and household composition matter. And unfortunately, we're not able to tease apart or disentangle the impact of the health insurance waiver and the cash. These are the impacts of that combined program. Thank you very much.